mean, I think right now, Selinexor as a combination up front looks like a very promising opportunity to sort of deepen responses early on, but we don't really know whether the best approach is to get the deepest response up front or to reserve even therapies in the second line. So there are some unanswered questions. And then, the idea of maintenance therapy I think is really intriguing in chronic diseases like the ones we're talking about, but I don't think we really know how to maybe induce a response and maintain a response. I think those are all open questions. There are a subset of patients, maybe 10%, maybe even a little bit less depending on where you practice, that will go on to transplant, the only curative option we have. Right. So one unanswered question would be, is it possible that if we synergize drugs like Selinexor and ruxolitinib, nab-to-madeline, ruxolitinib, these therapies that clearly have very anticlonal activity, can we get deeper responses so that ultimately that subset that might go to transplant, or even patients who may not have gone to transplant, become more attractive transplant candidates, may do better with transplant outcomes? So a lot of unanswered questions. I think it's paramount, as we keep saying though, that we need to be committed, the patient community, the physician community, the sponsors, everyone committed to following patients through. Otherwise we don't know what ultimately happens. We look at these very short outcomes, 6 months, and that's not sufficient. We owe the patients more actually to follow them out so we really know the full benefit of what we're doing.
Right, and our hope is with our relationship with the patient community that we can keep them engaged and informed, because this is a very empowered and committed patient community that wants to track their progress and know their outcomes, because these are longer term, more chronic diseases. But coming back to sort of all of the excitement of all the programs that you talked about and the question about what does this mean for the future, I think what I heard in all of that was back to options matter.
Yep.
We are bringing more options, single agent options, combination options, new mechanisms of action. And what that also translates for patients is not only will I be able to have more options over the course of my disease, but that might also mean I can actually start some treatments earlier. And if we could learn more about it, if we're starting treatments earlier, does that mean they are having better outcomes downstream and changing the course of their disease by starting treatments earlier because they have more opportunity to sequence later?
And that'll be my opportunity to take the pitch. Because there are so many questions and we don't have these answers, I really think it's paramount for when possible, for patients to participate in clinical trials. Because in these rare diseases, when we do anecdotal sort of treatments outside of the paradigm, we don't really learn from that, and it doesn't actually benefit the greater patient good. So I always admire patients that go on clinical trials because it takes a certain degree of courage and faith to go on a trial. I like the trials we're doing these days because they don't really take patients away from standard of care, and I think that's really important for patients to appreciate. You get standard of care plus either a placebo, so you're not robbing anyone from standard of care, or the study drug, often with options for crossover. So I would really implore patients, easy for me to say, but I implore patients to seek out those clinical trial options in these rare diseases. I think the care is better when you're on a clinical trial. I firmly believe that. I think the outcomes are probably better because you have much more attention, there's much more rigor to the treatment. And usually clinical trials are done in centers where there's a lot of expertise in these diseases. So I'm a biased person saying it, but clinical trials.
No, absolutely. I think we spend a lot of time with our patients educating them on why clinical trials should be an option for them, sort of dispelling some of those myths about it being a last resort. It really is part of a proper standard of care. But I'm going to take the opportunity to call our clinical community to action, because coming back to the survey that we just did, of those 676 patients, of which a fair number were actually seen at academic medical centers, only 14% of those patients said that their doctor had ever discussed a clinical trial option with them. So my call to action to the clinicians and the treaters out there is sit down with your patients and look at their clinical trial options and see what's right for them, because there are lots of new options out there. And I think we should be, as you said, thinking about this as more part of their standard treatment plans.
Absolutely.